The following podcast is brought to you by Kidney Stone Prevention Clinic of Orlando. Welcome to the Crystal Clear Kidneys podcast. I'm Will McPherson. I'm a podcast host, TEDx speaker, and media personality, welcoming board-certified nephrologist Dr. Paul Dreyer of the Kidney Stone Prevention Clinic of Orlando. Dr. Paul, as always, great to see you again. Welcome to the podcast.
Thank you, Will. It's great to be here again with you.
Excellent. You know, I've always wanted to say this. The doctor will see you now. Dr. Paul.
Sounds fantastic.
Does that sound good? Great.
Yes.
So let's lead off with this. Dr. Paul, a couple of weeks ago in a major publication, USA Today, they talked about home dialysis. And I know this kind of, it is in the genre, and we'll get back to stone prevention thoughts. But let's talk about this article. And Dr. Paul, if you could tell us what is kind of some of the benefits of having kidney dialysis at home versus at a facility? If you could launch with that, that'd be great.
So take a step back for a second, Will. The one thing the article says at the very beginning is patients crashing on dialysis, meaning either they didn't know they had kidney failure, or a lot of times they know they have progressive kidney failure, and they just, it's such a scary thought for them that they don't come back for their visits regularly. And then they show up in the emergency room and they need dialysis now. That's not who you want to be. Okay. If you're in that situation, you definitely want to follow with your nephrologist, because what I tell patients, if you go into this eyes wide open, you're going to do much better. So the first thing about home dialysis is it's a lot harder to do if you're in that group as opposed to the ones that prepare early and can get things lined up. So that's the one thing I want to emphasize that the article says from the get-go. But as far as the advantages, I think you asked what are the advantages. And so there's whenever I see patients, a lot of times they're on intermittent in-center dialysis. So they get treatments 3 days a week, usually Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. And the treatments are 3 to 4 hours in the United States. And they tell me, Doc, I get done with my treatment and I just feel wiped out, and I go home and I sleep the whole rest of the day. And the next day I get up and I'm okay. But then I come back the following day and then it happens all over again. And what I tell them, I said, then I would suggest you do home dialysis. And they say, why is that? And I say, because home dialysis, you're doing it pretty much every day. Sometimes you don't need it every day, but you might need it every day. But it's those abrupt changes when we're doing those in-center treatments where we're trying to get everything out of the patient in those 3 or 4 hours. And that change to the body is pretty jolting. As opposed to doing something gently overnight, every night is a lot easier on a patient. So that's the first thing I tell them. If you're having a hard time with dialysis wiping you out, then home dialysis is something to consider.
Wow. The article says only for 13% of patients. Is that a little understated?
No, that's actually, and not only that, Will, that's actually better than it used to be. It used to be under 10%. Yeah. And so the government, so back in 1973, the dialysis patients came under the auspices of Medicare. And so Medicare would pay for their treatments. And so that made it more widely available, because before that time, there's a lot of people that were considered not candidates, didn't get dialysis, passed away. So people thought, no, that's not right. We need to provide care for them. But in-center hemo is on the order of about $40,000 more per year per patient than if they do it at home. So the government clearly, from a financial standpoint, wants to do home dialysis. And patients asking me, well, which one's better? And I tell them, I'm like, well, the outcomes are equal, because if one was clearly superior to the other, then we wouldn't offer the one. You know, it's kind of unethical to say, we're going to give you the crummy one that doesn't do as well. So they actually both, the outcomes are similar in them as far as mortality and morbidity and that sort of thing. So the other advantage of home dialysis is those patients tend to be able to, they are often more often are able to stay employed and keep their private insurance. And that is a huge difference for them when they're getting worked up for transplant, or if they have to get hospitalized, than if you're on Medicare. And especially if you don't have a supplemental, because Medicare only pays 80% of the bill. So you need a supplement to pay for the other 20%, or you got to pay for the 20%. So
that brings up some issues. One thing though, I'm just taking a guess, Dr. Paul, that the percentage of patients using home dialysis at one point should raise, right? Because the article brought up a point about that, there's as anything after COVID, there's a dialysis nursing shortage. So you'd think there would be more promoting of home dialysis from Medicare and the hospitals themselves.
Yeah, I read that too in that article, Will, and I was trying to process that in my brain and figure out how would you incentivize patients? Do you do that monetarily? Is that fair? We're going to pay the home patients a little bit of a stipend and the in-center people. So that I don't quite understand how they pull that off. But it is thought-provoking, because you're right. Because the burden, that's the other thing about home dialysis then, is the burden of care is on the patient and their families, because you don't have somebody to come over and do the treatment for you unless you're super wealthy. So you're doing the treatment yourself, as opposed to going to a center where they have a staff that puts you on the hemodialysis.
Right. So the burden is off the center a little bit. You can take some of that off the plate. There's new companies that have emerged to manage CKD patients. What is CKD patients? Who are they?
CKD stands for chronic kidney disease.
Okay.
And there are 5 stages. Well, actually 6 stages. Stage 6 is when you start dialysis. So depending on what percentage of kidney function patients have remaining, as they have less and less kidney function, they progress along the stages. And those patients, just like the dialysis patients, even if they're not on dialysis, say they have chronic kidney disease stage 3B or stage 4, they have higher cost of care as well. And so what the government wants to do is have us take care of them as far as being gatekeepers and saying, do you need this care? Is this really necessary? And do you really need to get another CAT scan kind of thing, and look at that and try to be judicious in the care and order stuff that's necessary, but try to avoid stuff that they might not necessarily need, that's going to increase cost of care. So that's what they want to do. In the current system, it's so hard because everybody has a primary care physician, and when they go in the hospital, they have hospitalists that take care of them. So I trained in the olden days where we admitted the dialysis patients, we admitted the transplant patients. We got called at 2 a.m. saying, patient has a headache, can we give them Tylenol? We don't have that anymore. It goes to somebody else. And so it kind of takes some of that control away from us that we used to have. So that's the tricky thing. But that's the goal of what these companies are doing. They're trying to decrease the cost, and then Medicare will split the savings with that entity. That's the goal.
I think ultimately that sounds, though, like a win for some of the patients, right? That if they could do it gently overnight, instead of going into a center that, just works you over, right? Cleaning up as best as I can for 4 hours, it saves your day and puts a little bit of control in your back in you. Yes?
Yeah. Yes, absolutely. Especially the other patients that have a tough time with in-center hemo are these patients we have with heart failure. And because they don't have a good blood pressure, they can't, because when we're taking fluid off in the in-center hemo, it comes right out of the bloodstream. And then you're waiting for that fluid to kind of equilibrate and come from other parts of the body back into the bloodstream to support their blood pressure. Well, if they have a weak heart, they can't tolerate that as well as somebody with normal, normal heart function. So, for example, I had a lady, she just started, and I didn't know her. It's the first time I saw her on dialysis. One of my partners actually started her on dialysis, but they were reluctant to do home dialysis, and she has heart failure. And I said, I think this would be the perfect thing for her. And they said, well, that's funny because the primary nephrologist told them the same thing. What they were reluctant about is I don't know if somebody told them this or if they read this on the internet. They said, we're worried about the infection risk with the home dialysis. Well, wow. She's getting hemodialysis through a tunneled hemodialysis catheter that goes right into your bloodstream. I said, you're about 100-fold more likely to get an infection, and in that case, a bloodborne infection, than you are with home dialysis. So people kind of get this misinformation, either from, I don't know if it's from folks that aren't experienced with dialysis, or like I said, they're getting on the internet and getting some unreliable information. So we'll see. I mean, she's going to go back to her primary nephrologist. I said, think about it, but go back to your primary and see if you'd be willing to switch to home dialysis.
Dr. Paul, that is powerful stuff. And, that is the problem today is, your information is coming from all over the place. So that is very powerful stuff. And then you mentioned, just to make sure that everybody is listening is clear, insurance does not cover the cost for a healthcare provider providing the treatment, right? That responsibility falls to the patients and their families.
Yes. Yeah. I mean, they'll pay for the treatment itself, like for the supplies and that sort of stuff. But as far as like, they're not going to give you a salary to be the dialysis worker, that's providing the care for that treatment.
I think USA Today should call us, right? And and we should write a secondary article, talking about what they talk about, give them some more info. But yeah, this is really, really good information. And that's why we do podcasts, right, Dr. Paul?
Absolutely. Yeah. I mean, if this can help somebody, I'm ecstatic about that, because it's kind of a difficult, path to navigate when you're coming into this eyes, without any experience. There's actually something to be said about having, and this is something I'm kicking around here. And part of the problem with home dialysis is we don't have the infrastructure yet to take care of those patients as well as we could. For example, if I have a home dialysis patient that breaks a hip and comes in the hospital, now they have to go to a nursing home for 3 weeks and get rehab after they get their hip replaced. I can't do home dialysis on them at any facility. They don't have it. And I told the CEO of the hospital, I'm like, you guys own a nursing home. I think you need to have 5 beds dedicated to home dialysis so patients can go there and get rehab. It just doesn't exist right now, at least in Orlando. It might in other places, but that's one thing that I struggle with. And that's something that's got to be overcome.
Yeah, this sounds like it would help an awful lot of people if you can switch over to home dialysis, or at least partial home dialysis. It just sounds like you can do more stuff, in your life. You can work, go on vacation, do something, that you're not so tethered, so to speak.
Yeah, you're right. Because you're tethered to that schedule. I've got to go every Monday, Wednesday, Friday. If you're on home dialysis, let's say you want to go visit your sister, then you tell the company, hey, mail a week's worth of supplies to this address. You don't have to bring it with you. They'll mail it to wherever you're going. And then you have your supplies there to do your treatments. You just bring your little machine that does the treatments, but all the other supplies, meet you there. So that's one of the nice things you can do with home dialysis that you really can't. And so hemo, you got to arrange to get it, done in a center, and then you're again stuck with their schedule. So you want to spend time with your family, whoever you're visiting, and then you're doing your treatments at night, and then you spend all your time with the family during the day.
Yeah, that sounds way better, and it hopefully that becomes more and more prevalent as we move on. And speaking of moving on, Dr. Paul, obviously the name of this podcast is Crystal Clear Kidneys, and Dr. Paul works at the Stone Prevention Clinic of Orlando. So yes, let's talk about kidney stones. Last time we spoke, you mentioned that taking vitamin D can sometimes increase the risk for kidney stones. Is there any concern with other vitamins or supplements that kidney stone patients should be aware of?
Yeah, there's a couple of things. One is, and I have to declare, I have not seen this, but it is described that if patients taking high dose vitamin C, that can get converted to oxalate and contribute to calcium oxalate stones. I frankly haven't seen that. But that is definitely described. The other thing is, speaking of oxalate, I want to get back because we talked about the fluids, and this is one thing I want to clarify. And this is where you need to get an individualized workup, and that's where you come in. That's where I come in exactly. So we said if patients taking tea or iced tea, then they have less risk for stones. However, the caveat there is if they do have a lot of oxalate in their urine, black tea, there's certain teas that have a lot of oxalate in them, and those patients should avoid that. But patients that don't have a problem with oxalate can take in the tea without a problem. So that's why you have to know specifically each patient what their risk factors are. So I wanted to make sure I clarified that from a previous podcast.
Good stuff. Don't drink the sweet tea though, right? That's full of the sugar and fructose, which will definitely make the stones.
Which we can't metabolize, right? So that's why it screws us up. Tastes real sweet, but it's something that's not necessarily we're able to ingest. So the other thing is, if patients, sometimes they'll get some of these supplements that'll have different things in it, and it'll have citrate in it. Another thing it'll have in it is B6, and what B6 can do is be helpful for stones because there's some patients that have a problem metabolizing the oxalate, and B6 is a cofactor that works with that enzyme to metabolize B6. So if you give them a lot of B6, they can bring down the urinary oxalate. It doesn't work in everybody, but works in a few people. So that's sometimes you'll see that where that'll be beneficial. The caveat with B6 is if I do that with patients, I tell them to take, so normal B6 you need is maybe say 1 milligram a day kind of thing. And I have them take 100 milligrams, which is a super physiologic dose. It's much more than they need. But if there are descriptions of people take real high doses, they can get neuropathy. So I tell them, you get any numbness in your feet or something, like just quit it, because that has been described.
Cut it out, as they say. I've got a quick question for you. Now, obviously, some folks that are making stones are, I love this. And some folks that aren't making stones saying, well, I don't want to make stones, because we all can, right? It affects us all. So when I go to like large events, like a trade show or something like that, I do take a vitamin C high dose, right? Emergency. So, I mean, what should I think about that? Because you mentioned...
I think you'll be fine. It probably will be fine. You'll pee it out. And you'll have expensive pee because you'll do it, and you're like, oh, there's not that vitamin C going out there. So
it's gone.
So probably not going to be a problem. And again, you just want to stay hydrated too. That's the other thing. If you're at some event all day.
For
hot,
sure. Especially
if it's hot, then you want to stay hydrated so you don't concentrate your urine. But unlikely something like that would precipitate a stone just from taking high dose vitamin C, especially if it's just one day kind of thing. This is kind of a cumulative thing. If you're taking it every day, you've got high oxalate burden.
Dr. Paul, for those of us that don't know what oxalate is, could you tell us?
So oxalate is something it's not something that we produce. It's something in our diet. It also gets produced by bacteria, in our intestine. So there's some talk about whether probiotics can help. And there's a specific bacteria called Oxalobacter formigenes that supposedly decreases the risk of stones. But when people have given it, it hasn't really, shown to be effective, that sort of stuff. But so that's where oxalate comes in foods. Different ones, spinach, kale, so I get some of these people that are taking in smoothies and they think they're eating healthy, and they get this high oxalate load, and then they make a stone, and I'm like, it's from what you're eating. So generally you can find a list.
Another reason to see Dr. Paul.
Yeah. Well, and University of Chicago Litholink actually has this on their site of oxalate content of foods. And I tell patients, I'm going to send you the link because it's over 50 pages of an Excel program that lists pretty much anything you can put in your mouth and says, this has got a high amount of oxalate, moderate, low, or none. And I tell the patients, you probably want to have low or none if you're somebody with a lot of oxalate in your urine. Ooh. And moderate it.
So kale is called one of the wonder superfoods, and I have it. I have it about 3-4 times a week. You've seen me eat my famous kale chicken Caesar salad. So what should what should I think about that?
So again, I think you're probably fine. Well, if you've never had a stone, the majority of people are going to be fine taking in that. But if you definitely have stones and you have particularly if you have high oxalate in the urine, then you should moderate your intake.
Can I have that tested, oxalate in my urine? I mean, when I go for a well-being check,
that's part of our workup. Patients do a 24-hour urine collection, and one of the things included in the collection is the amount of oxalate in the urine. And you typically want it to be below 40 milligrams in 24 hours. And so I'll see some people and they're 20 and they're like, do I have to avoid spinach? I'm like, no, that's not your problem. That's not why you're making stones. I see somebody and theirs is 70 and I'm like, yeah, you probably shouldn't eat the spinach. But it reminds me of an anecdote that I heard another nephrologist say. He had a patient that every fall he would come to him with a stone and they'd work him up, and workup was totally normal. And they're like scratching their heads saying, why does this guy keep making a stone every year? Well, it turns out when they dug a little deeper, his mom lived in upstate New York and would make him a strawberry rhubarb pie and mail it to him. And so he'd eat the thing over the course of about 2 to 3 days. Well, rhubarb is one of the highest sources of oxalate you can get in your diet. So he'd get this huge amount of oxalate in just 2 or 3 days, make a stone. But then a month later, when he shows up in clinic, they would collect his urine. They're like, oxalate's normal. Well, because it already passed out, from what he had taken in. So when they figured that out, they said, just don't eat the strawberry rhubarb pie anymore. And the guy quit making stones. So that was an interesting one.
That's an amazing story. As we close out here, let's review again. What are some of the fluids to avoid for everybody? And for people that make stones, what are some of the things to avoid?
Well, like you already said, the Hawaiian punch, the high fructose corn syrup is one that
sweet tea.
That sort of stuff, because it raises, among other things, uric acid. And then the other one, again, who knows why? Because citrus fruits in general, citrus fruits are beneficial for stones, but for some reason, grapefruit, probably because it inhibits one of the key enzymes in the liver that metabolizes a lot of things, can contribute to stones. So those are two that you should avoid. And then again, the caveat with the tea, if you've got high oxalate in the urine, you might want to moderate your tea. But again, water is probably the best thing, but again, you can take in other stuff that shouldn't be an issue. But the ones that I cautioned about are the big ones to avoid.
And I've taken your advice, Dr. Paul. At night, I think a lot of people get dehydrated, including yours truly here. So I've been really slugging back quite a bit of water before I go to sleep, and I do keep a bottle on the nightstand. So yes, you do get up a couple of times, but I think it's worth it to keep yourself hydrated at night. That's 8 hours, and you get pretty dehydrated. So that was great advice, and I recommend that to everybody. Yeah, you got to get up a couple times maybe, but it sure beats making stones, and you're hydrated.
Well, and you and I are at that age where we're going to have to get up a couple times.
Anyways, you might as well.
So stay hydrated. Yeah, absolutely.
Oh, Dr. Paul, this has been an eye-opening session, right? So learned a lot about home dialysis. Like I said, even if it doesn't affect you, you probably know someone that does, and where it's heading and what they go through, and what a couple of options are, and getting your information straight is an issue. Well, it's just about everything, and especially about this as well. So this has been a fantastic.
And get ready early for the home dialysis. Like I said, when I tell patients, I say, this is like there's a hurricane out in the Caribbean, and there's a good chance it's going to hit your front door, and you can't wait till it gets to your front door to figure out what you're going to do. You want to have a plan in place, be ready for that. That's how you're going to do the best you can possibly do in that situation, and also get worked up for transplant. You might be able to get a transplant from a donor before you even need dialysis. So that's something else that can be beneficial, that the government also is promoting, because there's an upfront cost, but long-term that's less expensive. And those patients have a better quality of life. So that's something else that the article didn't really talk about, but also that we try to encourage our patients and get them plugged in early.
You mean USA Today was deficient in their kidney advice? Come on.
I don't know about deficient, but so it was something that wasn't included in the article. So from the nephrologist they were interviewing.
Yes. So, Dr. Paul, as always, it's been a pleasure.
Yes, I appreciate the time, Will, and great talking to you.
Thank you, Dr. Paul, for joining us. Once again, you can reach Dr. Paul with any questions at www.drpaul.com. www.kspfla.com or at 239-221-1281, the Kidney Stone Prevention Clinic of Orlando. Until next time, folks.